I'd like to thank everybody for joining today. We will get started here in just another 30 seconds. Wanted to welcome everybody who's watching on our Zoom webinar, as well as Twitter and our EON YouTube channel. I want to thank everybody for taking time out today. Why don't we just go ahead and get started? I'm Dr. Al-Zubaidi. I'm an interventional pulmonologist at National Jewish Health and also the co-CEO of EON. EON is donating our mission-critical SafetyNet solution for free to over 4,000 hospitals. I'd like to thank everybody who's joining me today, and also especially, first off, just thank everyone's service on the front lines, in addition to anybody who's supporting the frontline efforts. For this webinar, wanted to go through our agenda and discuss what we'll be talking about today. First, we'll start off with what's happening with cancer and COVID, why EON is prioritizing essential patients, real-time deferred patient curve. We're going to actually spend some time and dig into that. EON's commitment to rapid ramp up, and take some questions as well. And before that, we'll go into how to clear the backlog of deferred patients with standard operating procedures, EON SafetyNet, and essential patient reports. So let's dig into why we're here. As everybody knows, COVID-19 has disrupted the U.S. hospital and healthcare system workflow and focus, rightfully so. However, COVID-19 is also paralyzing the identification, management, and care of essential patients. And first, let's start off by defining what an essential patient is. So an essential patient is someone in which deferred or delayed care could be a threat to a patient's life, a threat of permanent dysfunction to an extremity or an organ system, a risk of metastasis or progression of a disease or condition, or a risk that a patient's condition will rapidly deteriorate if the procedure or surgery is not performed. So what's happening is that the current loss of focus on essential patient care is resulting in patient distress, which is resulting in long-term suffering, poor outcomes, potentially loss of life, increased morbidity and mortality. And so what we're doing is that we want to figure out how to get delayed care that could be captured post-COVID and return to normal hospital operations. But this won't occur until the resulting bolus of delayed care is managed in an appropriate manner. So let's dig into some of the deferred patient curves and discuss what we're talking about, and also why we're focused on this. So the reason that we're laser focused on helping essential patients is that 1.8 million people were expected to be diagnosed with cancer in the US this year before COVID. In addition, hospitals are already seeing a loss in revenue, up to 40%, and then also unemployment's on the rise. You can see that we've had end users and nodule coordinators who have been deferred or furloughed, and this also means that the patients that they're managing also are deferred. The scheduling, the coordination, that's deferred. So what we did back in early March is take a really aggressive and forward-facing stance that we are going to prioritize essential patients that need to be seen now. Why does this matter? So let's look at essential patient stats today as of April 15th. And if you would like to see the graphs and tinker with them, you can go on there right now to eonhealth.com. There is the diversion curve button. And if you would go there, you can actually see what we're going to be presenting today and fiddle with it yourself. So if you look, essential patient stats of the day, there's about 1.8 million diverted office visits just today alone. Total diverted patients to date is about 28 million. Took a stance that diversion started in late February, but really didn't ramp up until April, where the diversion rate goes up to about 80%. And we'll talk about that here in just a second. But the total diverted essential patient visits, and those are patients that we had defined earlier that may be at higher risk of mortality and morbidity if they're not seen in the next 60 to 90 days, is about 5 million patients. We also did a study into the procedures or APC codes, ambulatory codes like bronchoscopies, colonoscopies, ENT procedures, elective procedures, ambulatory procedures that are missed and diverted, and that's about 182,000 to date. if you are to look at the diverted essential patient visit graph here, what we're showing is that the blue line is the diverted patients during the there's executive orders in many states to stop non-essential care and focus on COVID care, which is appropriate. However, it does create this red line, which represents the missed visits. And so if you look here, this is the order of millions of patients, 60 million patients. So at the max in May, there is at least over 60 million office visits that are missed. Of those, the green line represents the essential patient visits. Now, the bottom tracker here in scroll bar shows hospital efficiency levels. And why is this important? It shows the difference in hospital efficiency levels that allow you to address this bolus of patients that need to be seen. And so let's go back to this real quick. Why are we saying that the hospital efficiency level is going to be at 90%? Well, normal elasticity is around anywhere from 2% to 7% based on specialty. What the heck does that mean? What it means is that even in my practice, I can't see face to face a patient in an office because why? It consumes PPE. And so that patient, we did telephone visits, we've tried to triage them, but at the end of the day, there's many patients who are, one, scared to come in, don't want to come in. There are offices which are just totally closed and not even doing anything, either telehealth or telephone call. And there most certainly is a bolus of patients that are adding that need to be seen. And so what we're saying is that while normal circumstances, hospitals would be able to ramp up their efficiency to anywhere to 102 to 137% based on the service line, this is not possible during COVID because you have to have a waiting room now that you can't pack solid with people side by side. You have to have PPE and masks. You have to have a standard operating procedure, which is going to decrease efficiency in healthcare, not increase it. So normal elasticity in normal circumstances now is lost. So what we're seeing is the effect not only of the backlog of patients, but if you are able to get your hospital up and your service lines up to 90%, that bolus at the end of the year is still above 60 million patients. So our first order of business and what we want to emphasize here is the importance of your hospital and its efficiency level. Here you can see the difference between 90 and 92%. At the end of the year, you're getting close to 50 million as opposed to 60 million who are still awaiting an office visit. And then if we look here and we get to a normal efficiency level of about 99 to 100%, you can actually work through your backlog before the end of the year. And so what we're saying is that while you may not be able to see patients now that are termed non-essential, it's of the utmost importance to identify the patients that are under the green curve that you actually need to see now, and it would be more appropriate to use your SOPs and your PPE on those patients immediately. And we can talk about within the nodule patients and lung cancer screening patients, what folks and what we're doing in our own clinics and how to segregate those. But as you can see, the likelihood of us being at 90% is high. And what we don't want to have happen is that this green curve does not get addressed. You need to address that curve first and then increase your efficiencies to the point where then you can address the red curve. Let's look at the difference when it comes to procedures. These are the ambulatory procedures with different levels in terms of 1 through 3 that would be missed this year. And you can see with the hospital level of 88%, your high margin elective procedures are not going to be able to be addressed this year in terms of a backlog with those type of procedures or throughput. However, if you were to increase these to normal, you can see that by the end of the year, not only could you take normal patient demand that you've had in the past, but you can also take the bolus of procedures and work through those this year. Now, identifying a Medicare level 5 and a 4 and making sure that those are queued up in June, May, June, July, as opposed to putting everybody together makes all the sense in the world. So what does that mean? You don't take your patients who have a high risk of cancer with an annual and push them both off. It doesn't mean that you don't push a high risk OB with a routine ultrasound and push them both off. You don't risk a patient who has risk of metastasis or progressive staging and needs treatment with somebody with routine care or surveillance. And so what we're saying is that you need to focus on folks early, starting in May, when you're able to start seeing patients again, and get those essential patients in first. Now, when it comes to new, if you look at the revenue for these efficiencies between 88% and 90%, the steady state that happens after June is of the utmost importance. Here, you barely get to positive in terms of recouping the lost revenue if your efficiency levels are around 88%. However, you can get above and start being profitable again and recoup some of those lost revenue for those procedures with increased throughputs and SOPs. So what we did is we noticed that this was a problem in early March, and we started creating what are called the essential patient reports. So this is an example of an essential patient report for in lung cancer patients. This must be very difficult to see, but as you can see at the very top, 4 Bs are placed up front: the nodule size, location, and different information. There are also advanced algorithms that we've created to identify patients at the most risk who don't have something scheduled. If a patient has, in terms of operationalizing these reports, we've done many things, and I want to take you through that real quick. So for a pulmonary service line, and this can actually be adapted to other service lines, is that a 4B or a patient who's an incidental, who is at risk of metastasis or being upstaged if they're not seen, you try to call that patient and try to get them in. And if you can do a telephone visit, perfect, and get them scheduled for a scan that is done or a procedure to be done, then that's great. Now, if that patient can't be seen, then you can put a note in that the patient wants to be seen in May or June, and then that would also, you have insight into that as well. As you can see here, this is an incidental cohort where the size of the nodule is shown on the right-hand side with whether or not they have a scheduled or expected exam. So there's mechanisms in which we were utilizing these essential patient reports to identify the patients and decrease that green line. Again, the green line's most important right now, right? The red line's important as well. They're all essential to us, but we're really focused on those patients that are that green line to take that curve back to zero. In addition, not only are we able to do pulmonary service line with SafetyNet and with our essential patient reports, we've really been burning the candle to get to, and this is very difficult to see, but this is all really neck to navel abnormalities of essential patients that could be renal cysts, liver lesions, pancreatic lesions, thyroid lesions, multiple types of essential patients that need to be seen. From there, in mid-March, we ended up looking at standard operating procedures. And as you can see, the difference between a 90% level and a 99% level is extremely important. So one thing is SOPs, standard operating procedures. So look at all these mobile CT scans, mobile PET scans that are out there sitting being unused, outpatient radiology centers, which are stagnant, also your radiology centers, which could be divided into COVID and non-COVID for increased throughput. But this is just an example of care coordination plus, where you take a mobile CT scan that is not being used, and now you have the ability to start to work through some of those patients that need to be seen during the COVID crisis. So these are things that you can do to mobilize to not only improve clinical outcomes, but you can also improve and lessen the revenue impact that you're taking. So all that said, what we've done is that we've taken these Excel sheets and then we wanted to embed them actually into the app for our current clients, and then offer something for other hospitals, because we feel like this is a global problem, not just in the US, but we're offering this to all US hospitals for free, is SafetyNet. And SafetyNet is where we can do a 7-day activation, very low yield impact to any type of IT. And we think it will not be a distraction to COVID responsibilities for hospitals, where we can identify these essential patients, starting with your pulmonary service line to restart hospitals. And it starts with essential patients, patients with no follow-ups, non-adherent, incoming, and then also a mobile nodule board. And what's important is that, and we can talk about technology and technology companies and healthcare technology, but really what I want to say is that if you have advanced tech stacks, you have the ability to take architecture that is enterprise ready with backend APIs and be really, really flexible with how you end up presenting and mobilizing different workflows. And so for this, you can see that obviously the PHI has been stripped. And if I want to take any screenshots or I do a screen recording, there is no PHI that could be listed. However, when I look at it, I see patient's name and their 4X listed up top, just like those Excel sheets that I showed you. And then in addition to that, you can see that the exams, if I cinch down on a particular patient, I can look at reports, I can send a patient to nodule board, and I can, as a provider for me, I can have the nodule coordinator who may be at home and they can, hey, send a nodule board. I can get on my application and I can look at every piece of record for that particular patient, send a note back to the coordinator, and they can help coordinate scheduling. This is how you get patients back in the mix. This is how you make sure that essential patients are being seen. In addition, what we did is we also created a CDC NHSN model. I know that a lot of companies are trying to do this. We completed this about a week and a half ago, probably about a month before other entities were doing it. It's free to use. Anybody can use this. And this is for patient impact. There's 3 modules. You can submit to the CDC. We have a mechanism in which we can aggregate all the data if you wish to share. And then if you have a multi-site IDN, most certainly you can create insights and other reports that are going to be more sophisticated than I think you will get anywhere. So that's also something that we did during this particular time. Now, what we want to, and so what's really important is that just going back to the patient curves, is that it's a multifaceted approach that is going to restart the hospital engines. And we got to understand that a hospital's core function is patient care. And we have to get our hospitals back to patient care. So what we've done is that we think that starting this out with SafetyNet plus SOPs. Listen, like I'm not a CNO or a COO, and we do have great SOPs that we're willing to share with folks that sign up for SafetyNet and help them out with different service lines. We are putting extreme focus on SOPs, standard operating procedures for every service line. How does a patient come into an office visit? How do they get seen in a radiology department? How do this throughput increased? So what we're doing is that we have a low impact mechanism where you can literally get activated within 7 days. If you're a current client, some of our clients have been leaning heavy on some of the services that we've been offering. Some of those services include the essential patient reports. We have SafetyNet that's been approved at an enterprise level for 90 hospitals and one of our clients. We have a mobile nodule board that's been mobilized. We're also centralizing the letter population and communication so that if you have diverted your workforce, that we have the ability to pick up the pace at a fractional cost or no cost, depending on the situation. This is something that I think that our whole team has gotten behind, and we're seeing dividends with the sites that have really leaned on us already. And we're very hopeful that every single U.S. hospital, which is eligible to receive this service for free, will sign up. Now, lastly, excuse me, I apologize about that. Before we open it up for questions, is that I just want to put up one thing. This daughter, we do this thing called One. Eon is one. There's convergence in healthcare IT. I think that this time has really created a situation where in healthcare IT, you can really see who's going to rise to the top and be a real partner in healthcare. It's time to fractionalize healthcare costs. It's time to focus on high efficiency and throughput. And I think that, if you're a current partner with us with Eon, you've seen that our approach is rapid learning with a company that listens. We are very, very hopeful to do business and to participate in helping our hospitals take care of this backlog. At this time, I'd like to take a second to just look at some questions, and let's take some questions now. If you guys want to go into the chat or the questions, we'll take questions currently. It looks like there may be some trouble putting questions in. So if we want to use the chat, let's use the chat for questions, because it looks like the Q&A won't allow people to put questions in. Here we go. Yeah, so the question is can we help with more than patients? So right now, the essential patient reports, in addition to the app, is specifically for the lung service line. However, we do have the ability, like I showed here, to identify other potential abnormalities that are outside of the lung. Our plan is to roll that out on a week-by-week basis. And then there's also a question, can we access the abbreviated platform? When you say the abbreviated platform, I'm assuming that you mean SafetyNet. And yes, the answer is yes. There is a very low impact 7-day activation in which you can get up and going on SafetyNet within 7 days with your actual patients from your facilities. What do you need to implement the app? So what we do is that we have a packet that we've created. We use your BAA. We have a standard enterprise MSA contract. We require just one single result feed from radiology reports. And that one feed gets stood up and we do the rest. And then you will be up on the app. And from our side, we can do this really in less than 7 days, but we're saying that by the time you get your packet in, the cutoff is on Friday, that you will have this up by the following Friday. Cost of SafetyNet, it's free. So if you're a current client, this is included. A lot of our have been utilizing this, some more than others in different aspects of it because needs are different. There is no cost May 30th. You have it free till the end of the year. As long as you cancel within 60 days of the end of the year, then there'll be no cost whatsoever, zero cost. So it's zero risk, zero cost. Can we handle enterprise data? Most certainly. We are a SOC 2 with a HIPAA compliant type 2 certified company with controls. We have gone through multiple enterprise architecture review boards. We are using the same architecture that we have prior with some of the toughest hospitals in terms of IT&S in the country, including LifePoint, HCA, Cleveland Clinic, MD Anderson, all of the in terms of our ability to rapidly scale and implement this at an enterprise level. We have that capability most certainly. The next question is that with the total disruption in job function for healthcare providers, time is limited. How have your implementations been going and what have you learned thus far? So quite frankly, the end users or nodule coordinators or coordinators of different service lines have been furloughed. Not all of them, but some of them have had a reduction in hours. What we've done is that we've 1099'd as much as we could in terms of what our company can handle and trying to pick up hours to make sure that these nodule coordinators, when they go back, they don't have to look for another job. And then also when it comes to the management of those dashboards, those end users can then even manage their own dashboards on our dime. That's one thing that we've done as well. The second thing is that we're trying to, and we are not trying, we are in the process of centralizing a lot of what those end do that we think is a headache. One of the headaches is mailing out letters. mailing out letters to PCPs, mailing out letters to patients. And so we think that we'll have a centralization of letter population stuffing, mailing, sending them with traceability, with a HIPAA compliant solution for centralization of that within the next 2 weeks. Offer that to both clients and to any SafetyNet users. Trying to reduce the burden and the number of hours that is used in the management and making things more efficient is what we've been doing. The next question is as EON users, how do we download the SafetyNet software? So when it comes to, this is available on Android already. However, Apple, we put this in for the App Store, which got put into review on Friday. It got put into the category of a sensitive issue because COVID tracker is on the application. And we expect that review to be completed either today or tomorrow, and you'll be able to have access to it. Now, if you're a current user, and let's say that you are an enterprise user, your corporate champions will have to say that you can use the mobile app. We went through an enterprise review on Friday and got it approved for 90 hospitals. So if you're within the LifePoint facilities, you are able to use SafetyNet immediately. If you are not a current client, you just sign up with the packet, get it in by Friday, and then you will have access to SafetyNet with your data and patients within 7 days. If you are not with LifePoint, we are going through the process of getting this approved through all the corporate channels, or even if you are a single site, to get approval that you can then actually use the SafetyNet app. The SafetyNet app is available for use currently. Any other questions that the team has? I know we kind of did rapid fire on some of these questions. And if you want to sign up, I would say that you go to www.eonhealth.com. There is an intercom button at the right-hand side, and then also it says check eligibility. The check eligibility is just that you're a US-based hospital. We would offer this globally, but we know regulatory very, very well in the US. And so right now we're offering this domestically to every single US-based hospital outpatient radiology center. And it looks like there are some questions too. Let me just switch over to the questions that are there. Okay, cool. Let's see here. How are you triaging essential patients? So essential patients fall into different categories. There is, so for lung nodules, very simply, and just so you guys know, there is a guidance document that's going to be out of CHEST, a group that was spearheaded by Peter Mazzone. Nicole Tanner's on that group as well, among others from Cleveland Clinic and also from the Medical University of South Carolina. So there will be more guidance in regards to pulmonary nodules in terms of what's essential and what's not, who to scan and who not to scan. What we have seen from our clients is that they are bringing in folks for lung cancer screenings that are 3s and higher and having them scanned. If there's a procedure for a 4B or higher, because a 4A is either a PET scan or a 3-month follow-up, if it's a 4B that needs a procedure, those procedures are coming in. If it's an incidental patient, then those patients who need a diagnosis now are being brought in either for scans or bronchoscopies or surgical resections. There is some varied guidance from the American Surgical Societies and other societies. But what we do in my clinic is that I'm seeing it's a telemedicine visit for 3s and higher, diverting and delaying the 1s and 2s, not doing baselines. And then for incidentals, it's looking at everybody who's 8 and higher and deciding whether or not they need to have a procedure or a scan within the next 30 to 60 days and doing that based on clinical judgment. And the next question is, what assumptions did you make when generating the diverted essential patient charts? Yeah, great question. So we used Medicare 2018 discharge data as well as, all comers for Medicare. So for office visits, and that was about 880 million visits in 2018. And then we just divvied that up day by day in terms of the amount of estimated visits. When it comes to the procedures, that was Medicare data from 2018 on ambulatory procedures. The biggest assumption to me is that demand is going to be the same in June and July, excuse me, as it is as it was last year. So what that means is that if I'm looking at a backlog here and you're at 90% efficiency, this is assuming that you're going to have the same demand as last year, right? So that was one assumption as well that we made that I think is one of the bigger assumptions. Diversion data in terms of 80% diversion was also something that we looked at. More anecdotal evidence is in terms of office visits that were being deferred in terms of the percentages. But real diversion data is easy to create, and we can do that specifically for hospitals if you're interested in that. And then Lynn's asking, can you explain what criteria is used for the screening patients to put them into tier 1, tier 2, or tier 3? Great question. So Lynn actually has received an EPR. So adherence is defined differently with different lung RADS categories, or for an incidental patient based on the size of the nodule. For example, a lung RADS 1 and 2 patient has an expected exam in 1 year. So let's say that somebody on April 14th, 2019 had a lung RADS 1. They would be expected for their next scan, their annual scan, April 14th or 15th of 2020. And so what we're saying is that adherence gives a buffer, and that buffer for a lung RADS 1 is 3 months. So 15 months after they had their initial visit, they're at risk of never following up. And tier 1 shows you patients that are going to become non-adherent in 7 days. Tier 2 is 14 days. Tier 3 is 1 month. Why is that important? Excuse me. We want you guys to be proactive before patients get to the never follow-up phase and risk of never follow-up. So the EPR is set up in a way where, and here I didn't show you guys at the bottom, but there is different tabs that say non-adherent, incidental non-adherent screening. There is non-adherent, incidental, and tier 1, tier 2, tier 3. And so we've broken those out in terms of the patients who are already non-adherent and they're at risk of never following up. And then tier 1, tier 2, tier 3 are the next most essential patients that you need to see in order to make sure that they don't go into that level of never following up. So, and Lynn, we can explain that a little bit more if you need more explanations on 1, 2, or 3. But that's once you get ahead of that non-adherent incidental screening, the no follow-up incidental and screening, then what you do is you start going through tier 1, tier 2, and tier 3. And this goes back to the fact that we want to handle right now folks that are in the green, and then get to the folks that are in the red on that red curve, if that makes sense. Can I see real-time data like the graph you showed from my facility? Absolutely. So we have what we would need in terms of the data from your facility in terms of previous discharges, and then also discharges from the past month to create a specific diversion rate. And then efficiency rates we can also create for you, very much like on our website, but specific for your facility. We can most certainly do that as part of SafetyNet sign up. So if you put that packet in and you say, I want to have these diversion rates with SafetyNet sign up, we would do that in addition to SOPs. So SOPs and real-time modeling is something that's well within our capabilities to do at scale for every single hospital. For us, it's good to have your own hospital real-time models with diversion rates that are real, because then you can look at your efficiency ratings and you can take action into your efficiency ratings for different service lines. I think we can even break it down as service lines. So you could say, your pulmonary, your cardiovascular, your primary care. Here is what your diversion rate is, your true diversion rate, your efficiency rate, and you can start to actually dig into interventions operationally to that improve throughput. So most certainly, whoever it's an anonymous question. Looks like we've done all the questions. I'll hang out for another probably 2 or 3 minutes to take any more questions. Really just want to thank everybody for joining today. I tell you, the past 4 to 6 weeks have been, I've been in a tunnel, just really, really grinding on, these aspects that we think are needed to mobilize on fast. There's still a lot of work to do. Um, and just wanted to say thank you to all of the end users and to all of the nodule coordinators who are really, grinding themselves to in a very difficult scenario where it's very difficult to get patients to feel comfortable to come in. There's one more question, it looks like, from Matt. Let me just get to that real quick. I can't see that. Christine, do you mind showing me where that's at? Oh, Matt, I see it now. I know you probably stated this fact, but I missed it. Considering our essential patients, which corresponds to the green line. Okay, yeah, perfect. So that's a good question. So here, what we did is that we looked at different articles in terms of percentage of patients that are essential. And this is another assumption that's made, that we just stated that approximately 20% of all outpatient office visits would fall into the category of essential, where if they're not seen within 60 to 90 days, they could then have increased mortality or morbidity because of that. It's easier to not make assumptions with procedures, because there's different levels, although the complexity of a level doesn't necessarily mean that that patient is essential. So that's definitely another assumption that we made in terms of who is essential versus who is not essential. The definition of essential is not yet determined. Like I said, there are certain entities that are creating guidance documents. Like I said, there is one that's coming out next week. They're in press now with who to scan and who not to scan. We will adjust our models once that data gets delivered next week. Every day we have a daily debrief, which is about 10 minutes. We present new data. More than it's every day at 1 p.m. Eastern. Please join us on Twitter or Eon. It's a live broadcast that we do. Very, very short. This presents very, very new data and things that we think are important. We must restart our hospital engine to get back to our primary objective of patient care. Stay safe, stay distant. Make sure you see your essential patients, and we'll have more tomorrow. Thank you, guys. Thank you, everybody. Really, really appreciate what everybody's doing.